Okay.
Yeah, actually, this is David. I just joined the meeting. I'm probably like 7 minutes late.
Fine.
I don't know if I miss anything.
No, we were kind of just figuring out where we were going to start. And I was saying to use that blueprint as a guide for where to put your time. You know, if there's 2 or 3 pages or even a whole page on something that has one question and you're feeling the crunch of studying, put your time somewhere else where there's 6 questions coming out of a section, you know, that type of thing. I mean, it's just, if you can cover it all, great. If you can't, you have to get strategic, you know?
Thank you.
You're welcome. So wound healing, that's where we were, right? Since that does have 3 questions, it's probably not bad to cover. I'm just trying to get to where it is. 151, page 151 is what it looks like for me. Dysfunctional types of wound healing, types and phases. Okay. All right. So in this wound healing part, I know that they say for you guys to know every single blue term in the book, but you know that that's my AOL mail, I'm sorry. You know that's obviously not possible everywhere, right? But here, a lot of these terms could play into what's on your test, right? So if you start at wound healing on 151, conclusion of inflammation is healing and repair, right? So if, where are you? I see yours. Do you see that one? Okay. If you just joined, you won't see anything from behind, but if you were here, I don't know why it didn't show up for you. So of course, with wound healing, if we can have return to normal function and structure, that's optimal, but that doesn't always happen depending on the wound, right? So if you look here on the bottom of 151, it's showing 2 different things, healing by primary intention and secondary intention, right? Complete with pictures. So this is a good way to visualize, right? You're going to see a lot of these words coming up here. But that's probably a good thing once you have a little grasp to come back and look at. Like I said, blue terms. Hold on, let me look at my other notes here too, aside from what she gave us. So much of this. We've covered so much of the stuff on your test. Yeah, very true. But if they're gonna do a geriatric question, they'll put it in your blueprint, like normally. Pediatrics usually the last chapter for the modules. I think this one's different. But normally you'll see like every respiratory has a pediatric chapter, cardiovascular has a pediatric chapter. But the geriatric, they normally point to, but yeah, it is important. Okay. She did point them out, good. Yep, once we get through this, we can go back if we have time today for sure. For sure, because that is a big thing on there. Okay. So in here, like I was saying, primary intention and secondary intention, right? So primary intention, your wound's pretty much healing under conditions of minimal tissue loss. And you can see the difference in the picture. Obviously that pink, that darker pink area is much larger on that secondary intention. And you see the wound contraction, right? Know those little stages, like you see the coagulation, proliferation, remodeling, maturation, see all these words in the middle, remodeling taking weeks to months, right? Proliferation 3 to 14 days. Just have a general idea of what's happening in each place. So if you can literally picture this, or even remember, like, where was remodeling? It was at the bottom of the page, so that's probably the one that takes weeks to months, like that type of thing in your head. Again, blue terms, repair being replacement of destroyed tissue with scar tissue, and then definition of scar tissue. Primarily of collagen that fills the lesion, restores strength, but cannot carry out the function. So obviously you already know scar tissue is not functional. Okay, we already talked about primary intention a little bit, and those are more the words that I told you just to look over, right? So minimal tissue loss, close deposition of the wounds, very little sealing, epithelialization, and shrinkage, which is the contraction. Remember, there was more of that on the secondary intention side. And then when we get down to secondary intention here, the book, let's see, probably a good example, although we haven't talked about pressure ulcers. Just know that's more scar tissue, longer formation, and obviously is not going to be functional. Think of that for secondary intention. Primary intention preferred. Let me look back at our thing here. So there's 3 questions coming out of what we were just talking about. Let me see if there's anything else. And I know I'm kind of breezing over it a little bit, but because there's not a lot of a concept for me to go over, I don't want to kind of beat a dead horse. That table in 151, again, use that as the reference, okay? If you guys want to go over that any more in depth, or is that okay to kind of skip? Oh, I can't remember if this is important in this chapter or in another chapter where we talk about wounds and skin again. So we'll just kind of go over it because the more times you hear it, right? So on page 153, it's talking about dysfunctional wound healing, right? And on the bottom, like the very bottom, it says hypertrophic scar. So this is talking about dysfunctional collagen synthesis. Remember, scars, collagen, right? So with excess production, you can have 2 things. You can have a hypertrophic scar, which hyper means lots, right? I mean, that's excessive, lots. And trophic is the growth. So hypertrophic scar, it's raised but remains within the original boundaries of the wound. Okay, so meaning maybe I would normally have a flat scar, but in the exact same spot, it's just super raised. There's a lot of collagen growth. Versus a keloid, which if you turn the page to 154, you can see the difference here, right? A keloid is raised, but it goes outside the original boundaries of the wound. And that can cause a lot of problems, which we don't really have to talk about now. But I don't remember if it's this test or another test that this is something that we visited in the past, to be honest. So you just look at it. The keloid's obviously much larger, and it can stretch out. Like if there's a chest wound, it can go all the way across. It can be pretty restrictive. Another thing on here, they talk about wound disruption. So if you have a wound that's sutured closed, it's at risk for dehiscence, right? So the wound pulls apart at the suture line. That's obviously something that needs immediate attention if a wound opens up, right? Did she tell you guys anything about geriatric for wound healing? Because I don't have anything on my notes, but if she changed something, maybe she told you guys. No. Look at the table. All right. 154. Sure, you can come in. There we go. Okay. I don't have much in those tables, unfortunately. But I'll tell you this. When you get to the test for these geriatric questions, if you can sit there and think about, as we get older, all the things that happen to us, like if you picture a really old person with their paper thin skin, their diminishing sensations, I'm giving you a lot of things for old people, but just picture it. You can probably always choose the right answer. You know, like their bone loss, as we talk about other things further, like later, like if you think about it, you can probably guess what the right one is, but not a bad idea to read over those tables. What do you guys want to do? It looks like in chapter 7, there's 1, 2, 3 questions. Do you want to put time there today? That's my thought. The big stuff is always my thought. I don't know if I have anything more specific than what's there. So if we're just touching on that briefly, I really don't have much to narrow it down for you, unfortunately. And I know that there's a ton in those, you know. Yeah, it's at least a few pages and I don't have much to narrow down. What Kayla said. Okay. Okay, so I'm hearing lots of acid-base balance, sodium, which somebody else was asking for. The innate immunity. Okay. No, you're fine to type it. I try to check this, but it doesn't always. So I'm not ignoring you if I don't answer you. It just doesn't always pop up. Electrolyte imbalances. Okay. Do you guys feel good with the stress response? There's only 2 questions in there. This is sympathetic, parasympathetic, right? You're out of this whole chapter. Maybe we'll get to there. We'll go to your other stuff. Terminology on there. Okay. All right. So let me write this down. Even though I know you guys will keep me on my toes for it, but. Hold on. 1 second. So we'll just really hit all the major things then. Acid, sodium, malt, innate. 3 protein systems, okay. Taylor, with that, you're gonna have questions on some of the stuff with potassium. You will have some calcium, phosphate, mag questions, but not as much. Yeah, not as much. I would say you'll get a couple out of that table, that purple table. You remember what I'm talking about? Okay. Yeah, I would just know the general things for that. Just kind of like pick the big things out. Let's see. Let's go back. The table for calcium, mag, and phos is on 126. It's really the big place that they talk about it. You're welcome. Oh, see, you got it. And then what I was saying for that is you guys obviously know your values in general, right? And know them out of the book. And know like hypercalcemia. What are the major causes for that? And that one's pretty easy, you know, hyperparathyroidism and cancer. Like that's what you have to think of for high calcium levels. Low calcium levels, for me, I always think blood administration because there's something in it that binds to calcium. But you can have, let's see, decreases in parathyroid hormone and vitamin D. So obviously if hyperparathyroid causes high, hypoparathyroid would cause low, right? Nutritional deficiencies. Phos, I would say for me, typically, if I see phos problems, phosphatemia, it's a lot of times it's renal failure. You know, there are other things on here for high phos like cancer from treatment, but that's the big thing for me. And then low phos, it's going to tell you is vitamin D deficiency, and then use of magnesium and aluminum containing antacids. Kind of stressing that part, the antacids, right? They can make your phos low and they can make your magnesium high. So if you look under magnesium, one of the things for hypermagnesemia, like let's say you have a patient that comes in and their magnesium is super high and they're not a renal patient because renal patients can have all sorts of whacked out electrolytes, right? One of the first things that you need to think about is antacids. And I always give the example of my grandfather that had Alzheimer's who was eating antacids like candy and we didn't know. Had we taken him to the doctor and they'd done blood work, they would have been really confused, but it could have been his antacids, right? And then low magnesium, always think of alcoholism. So malnutrition, alcoholism, those are the big things there. Not limited to, but just examples of what I would look at. Okay, so let me go back up here. The good news is that for a lot of you guys, this is going to be quite the review because we spent a lot of time in module 1, right? So things in module 1, distribution of body fluid and electrolytes. So that's on page 114, okay? Let's see here. There we go. So page 114, just to give you a base, things that you should pay attention to, right? It talks about total body water a lot throughout this chapter. So that's about 60% of adult body weight, right? What do we have? We have intracellular fluid and extracellular fluid. Intracellular is 2/3 of the total body water, which is pretty crazy to think that out all the water in our bodies, 2/3 of it is inside the cells, right? Extracellular fluid, all the fluid outside the cells, only 1/3. So that includes in the vessels, the interstitium, everywhere else in the body is the extracellular fluid. So remember, most of it's going to be inside the cells and only 1/3 is outside the cells. Another thing here is, where do the electrolytes like to be? Some of them have more of an affinity to be inside the cell, and some of them have more of an affinity to be outside the cell. There's a chart, where is it? On 115, and it just kind of gives you an idea. Do you have to memorize this chart? Absolutely not. But if you look, the big players here, like sodium, extracellular fluid, right? It even says here on your book, extracellular fluid contains large amount of sodium and chloride and a small amount of potassium, where the opposite is true of intracellular, right? So potassium really likes to be inside the cell overall, and phos and mag are greater in the intracellular fluid. The sentence that they put inside this paragraph is just so horrible. This how they organize these two sentences, really. But know that, right? Sodium likes to be outside of the cell. Potassium likes to be inside of the cell. We'll talk about that more in another chapter, sodium-potassium pump. But that's a nice little table. And I'm only talking about the electrolytes here. Well, that's not true. Focus on the big ones that are in the chapter for the most part. But that table's good. I mean, in the writing, you know what I mean. The paragraph. So, the sentence at the top of the next paragraph, it says it really well. So, although the amount of fluid within the various compartments is relatively constant, solutes and water are exchanged between compartments to maintain their unique composition. So there's always an exchange going on, right? Salt and water. Water likes to follow the salt, right? We'll talk about that more in alterations in water movement. The next big thing that is on here is the Starling forces: filtration versus reabsorption, oncotic versus hydrostatic pressure. So no, Starling forces are the same thing as net filtration, right? Capillary, so there's the 4 forces listed here. You guys haven't already looked at them. You have 2 capillaries and 2 interstitials, right? Capillary hydrostatic pressure, capillary plasma oncotic pressure, interstitial hydrostatic pressure, interstitial oncotic pressure. So remember in our talks on previous sessions, in my head, I remember oncotic because the other word for it's osmotic. I remember it for things like if you've ever had to give yourself, a family member, a patient, whatever, magnesium citrate, right? It is a laxative and it is an osmotic laxative. So the way that it works is this high concentration of magnesium salts go into the body and it pulls water into the bowel because it's got such a high level of salt, right? So it pulls the water in. So it's a pull, right? The hydrostatic is a push. So hydrostatic pressure is a push, the oncotic is a pull. And it's pushing water and pulling water. So another thing I have highlighted here, and she mentions on your study guide there, or whatever it's called, your blueprint, is fluid moving out of the capillary into the interstitial space, filtration, or fluid moving back into the capillary from the interstitial space is reabsorption. Right, so reabsorbing back into the vessel or filtering out into the interstitial space. excuse me. Okay. So alterations in water movement, just one question. But basic highlights here, know what edema is. Excessive accumulation of fluid within the interstitial spaces, right? So it's fluid in the interstitial space. It can be pitting edema, where if you push, it leaves a mark. It can be non-pitting edema. It can be generalized and be everywhere. It can be localized to a site of injury, or maybe from, dependent and hanging. It can just be there. It can also be pulmonary, cerebral, lots of different types of edema, right? Supportive measures, elevating edematous limbs, using compression stockings, avoiding prolonged standing, restricting salt intake, and taking diuretics, depending on the situation. That was like a very abbreviated version for that one question that's in there somewhere, right? Sodium, chloride, and water balance. One question in here. Okay. I don't want to spend too long because I know we've talked about this before, and there's one question in this section, right? This page. Big things to know here. Sodium concentration is going to be regulated by renal effects of aldosterone, right? And water balance is regulated by ADH, antidiuretic hormone. So those are your two things. Sodium's going to be your aldosterone, and then the water is going to be antidiuretic hormone. Okay. You guys remember the renin, angiotensin, aldosterone system? There's a lovely picture on the back of page 118 that kind of gives you an idea, right? It gives you the flow of what happens. The big things that I want you to take from there without spending a while going over that chart and the flow is what triggers things, right? So I don't remember if this is good. All right. So the triggers for aldosterone, a couple of things. Circulating blood volume or blood pressure is reduced. Low sodium levels or high or increased potassium levels, I should say, right? That's going to trigger your aldosterone, which starts with the renin, right? Renin, angiotensin, aldosterone. On the back of 118, you'll see that. But once those sodium levels are up, it's going to kick off that whole cascade, and eventually the aldosterone is going to be secreted by the adrenal glands, and its hope is to hold on to more sodium in the kidney, and it's actually going to get rid of some potassium in the process. Okay. Your book says aldosterone promotes renal sodium and water reabsorption. So just to tack on to what I just said. Self-limiting cycle. At the end of that cycle, the ADH is also released, which causes vasoconstriction. So renal perfusion is restored, right? And the restoration inhibits further release of renin. That's more time than I intended to spend there, but just remember what regulates what. What regulates your water, what regulates your sodium, like the big regulators anyway. And then understand how that cycle works. There's so much in that little paragraph underneath for that one question. So you guys obviously know she's casting a really wide net for that, right? Okay, alterations in sodium chloride and water balance. So here we have 6 questions. Hold on one second here. Does everybody have that little table that I did? I think I have some more notes in my phone. Yeah. Okay. It's nothing fancy. But here it is. So I really don't, we're about to talk about this. So there's a little table and feel free to add to it. I did it super basic and I will explain it more in a second here. Sorry. Okay, good. Sorry, guys, I'm just looking. I want to make sure I cover every point for you guys that I have in multiple places here. I am so glad that I opened this. Give me just a moment. I'm sorry. You guys got to make sure you know those values of those electrolytes. Okay. All right. So anyway, that was enlightening. I'll probably reference these notes again here. So here we are, alterations in sodium balance. Another thing that I want to stress, because I've used both words, but know that antidiuretic hormone is also called vasopressin, okay? Know it by both things, ADH and antidiuretic hormone, vasopressin, right? So know all 3. Electrolyte imbalances, terms for classifying water balance. Okay. Sodium chloride and water. So the first thing I'm going to go over here, just because it's right here, is isotonic, hypertonic, hypotonic, and then, wait. And classifying water balance. So the table that I sent out to you was about water balance. So we'll get to that in a second. The water and solute imbalances, table 5.5. So it talks about, it really just gives you the definitions here, right? So serum osmolality, osmolality. Remember, osmolality is really the amount of solutes in the sample, right? So if something is hypertonic, there's a lot of solutes like salt. Like hypertonic saline has a lot of salt in it, right? Hypotonic is going to have less solutes in the fluid. A little example. It gives you a little bit more information next to the tonicity with the mechanism. So isotonic, those are the fluids that we want to give people, right? Most of the time. So what's the important thing out of here? I don't know if any of this is going to be helpful for the test. So let me think here for a second. Just as a few notes in looking at this. So when I think of hypertonic saline, like I was saying, or a hypertonic solution, I think of hypertonic saline. So for example, if somebody was severely hyponatremic, typically what we will do is start them on hypertonic saline, right? Normally like 3% saline instead of the 0.9%, it's 3%, to slowly bring up their sodium to a safe level. Hypotonic, when I look at that, talking about hypotonic fluids, a big thing with that is that cells swell in hypotonic fluid, right? So the reason that I'm saying that is there's parts of your book that talks about that, especially with hyponatremia, right? So if I'm hyponatremic, the blood that's coursing through my vessels is low on sodium, right? And so why that's dangerous, once we start talking about it a little more with the hyponatremia, one of the big dangers for that is going to be cerebral edema, okay? Because the water that's in those vessels is going to go to the higher salt concentration inside the cells at that time because we're hypotonic, right? And it's going to cause swelling of the cells. So how to present the rest of this here? Okay. So the fluid alterations, right? You have isovolemic, hypovolemic, hypervolemic, and it talks about that in hypernatremia and hyponatremia. It's all about the balance between the salts and the fluid, okay? I really hate it, hate this subject. I wasn't looking at anything in the book, Harmony. I'm just looking at my own notes. Just make sure you know the values because you need to be able to identify if something's considered hypo or hyper. And I can guarantee you that you're going to use that on your test. You're welcome. I just reading my notes made me be like, I need to say this out loud. Okay, so my little table. Pulling it up here. So what you'll see here is that I kind of just pulled a little sentence and sometimes a little more from the book because just to give you an idea of what's going on, right? So you'll see hypernatremia. It's talking about, I kind of tried to say what's each thing. So loss of free water with near normal body sodium concentration. So you're losing fluid from diarrhea, burns, vomiting, but it's not enough to have a big deficit in fluid volume. So they're calling it iso, which is like equal volemic, like you're euvolemic. Everything's okay with your volume, even though it's a little low, but your sodium has still risen. Okay, isovolemic is kind of a weird concept because you are having loss and gains, but it's not enough to cause a problem volume-wise, okay? So I'm just trying to show, that in this chart. So the isovolemic, it's not a problem volume-wise, but it is a problem to where it's affecting your sodium levels, right? So for the hypernatremia, there are some examples of what can cause it. Hyponatremia, one of the big examples is SIADH, which we'll talk about in a future chapter. Syndrome of inappropriate antidiuretic hormone. It's where your body actually is holding on to more fluid. But it can either land in two places, and on this chart, or in this part of the book, it talks about it being isovolemic or euvolemic, right? So losing of sodium without significant water loss. The volumes are okay. So on this chart here, talking about hypervolemic. So with the hypernatremia, increased total body water, but a greater increase in sodium. So this is more rare, right? One of the examples it gives in the book is administration of 3% normal saline. So hypertonic saline or hypertonic solution, like I was just talking about. Just checking to make sure nobody had messaged while I was talking. There are other things that can cause it, but that's an example. Like we're giving a lot of hypertonic saline. So if we give a lot of that over a course of time, it can make people have volume overload, right? And also higher sodium because of it. So with hypervolemic hyponatremia, so total body sodium's increasing, and then there's an increase in total body water and causes dilution in the extracellular fluid space, which remember that includes our vasculature, like at things inside our vessels and the interstitium, right? So that's kind of like a two-part, right? The total body sodium increases, and then the water flows to it, causing dilution. And that means when we look at that sample, it's going to look like low sodium because it's been diluted. Okay. CHF, cirrhosis, you'll see edema in this type of setting. The other thing, the hypovolemia, so loss of sodium with relatively greater loss of body water. So this is basically the examples they gave were loop diuretics and mannitol. Mannitol is an osmotic diuretic that we give. I've only given it for patients with traumatic brain injuries with brain swelling. We're trying to bring it down. Same idea. Well, I'm not going to go there. Okay. So basically, you're going to end up peeing out your sodium, right? You're losing a lot of water and you're using a little bit of sodium. So because your water loss is greater than your loss of sodium, you're going to end up being actually hypernatremic. Does that make sense? The hypovolemic hyponatremia, loss of total body water, but greater loss of sodium, right? So things for here, prolonged, you'll see this. So the vomiting and diarrhea are in both places. They're in isovolemic hypernatremia, and then they are also in hypovolemic hyponatremia. But the difference is these are prolonged vomiting, severe diarrhea. One of the big things that we do when somebody's dehydrated is you try to rehydrate them, right? Like at home, you're like, you need to make sure you drink. You got to replace all that fluid that you're losing. But if we do it with free water, right, just normal water, what it does is it actually lowers your sodium down. So that's why those electrolyte drinks are important with replacing. So here, where was I going to go with that? Lung vomit, severe diarrhea. So we're really just getting rid of all of our sodium and a bunch of other electrolytes. People who vomit a lot are also at risk for really low potassium. Like people who are pregnant, you'll see that in your OB. They have hyperemesis gravidarum, whatever that thing's called. They're at risk for electrolyte imbalances, like really low potassium, which is scary. So anyway, with the sodium, prolonged vomiting, severe diarrhea, that can cause hypovolemic hyponatremia because you're getting rid of a lot of the fluid, the total body water, but you're getting rid of even more of the sodium, okay? So just remember that. It can cause hypovolemic hyponatremia. Also remember that if, how do I say this? So, patients sometimes have the nasogastric tubes, an NG tube that's hooked to suction. So if somebody's putting out a lot in that as well, that can be another place that we're losing not only fluid, but also electrolytes like sodium, right? So lots of NG output, it's practically the same thing as vomiting. Like we're pulling it out of the stomach. So put that in the same class, right? You're gonna see a question from this table. You're gonna see a question from this subject, I should say. Does it make sense to everybody enough? I know that it's kind of, you just have to really think about it. But if you can look at that table and just understand the basic concepts, even if it may not be your favorite thing, it should help. Okay. So just looking at your stuff. So the other thing that it says on here, because I feel like we talked about the iso, hyper, hypotonic, and then the volume stuff there. So I think we've covered that. So the next thing it says is electrolyte balances related. So basically everything about those, I'm guessing. The table's the one that I linked to in the chat for the volumes. But it's really the subject. I didn't write every single thing that I said, like I kind of expounded upon it, but it's a concept that you're definitely, I would know. That's what I was getting at with that. So as far as everything goes with your electrolytes, I don't think, aside from the table that we referenced earlier, that there's a great one, right? Definitely know your volumes. Definitely know your values. Know the symptoms of hyper and hypo for them, okay? Trying to think here. So one of the big things I would say with the hyponatremia, it's something that I already talked about earlier, and it's on the top of page 121. I know I kind of skipped over hyper, but 121, it talks about most life-threatening consequences: cerebral edema and increased ICP, intracranial pressure. Neurologic changes, including lethargy, confusion, apprehension, seizures, and coma. So obviously it goes all the way down the line there, right? So with the hyponatremia, muscle twitching, depressed reflexes and weakness, nausea and vomiting. And then depending on what, it kind of goes into a hypervolemic versus hypo, what your symptoms could be. But just imagine hypovolemia versus hypervolemia, right? Like what you would see if somebody's hypovolemic, they're probably hypotensive, tachycardic. And then hypervolemic, weight gain, edema, ascites, JVD. But the big thing, again, with hyponatremia is that risk for cerebral edema. They could be if you feel like they're helpful. I used to have a chart in nursing school, and I only find it like when I'm on break from tutoring. So annoying. Like what was helpful for me in nursing school was our teacher had us do a chart with, 6 squares. You know what I mean? And in each one, it was kind of what I was saying to remember. Like the top was the values, normal values for each thing, and then brief description of what it does, because of course these things have so many roles in our bodies, right? And then like hyper, what some of the major symptoms were, hypo, what some of the major symptoms were, and common causes. And even making that in itself will give you an idea, but then when you are taking the test, you can literally think about it and almost envision like, oh my God, I can't remember which one that was, but I know that I wrote them out, and I know chloride. You're not going to have a question on chloride, I bet, but that's not even a good one. Potassium was on the top right, and I think under that was renal patient stuff. You know what I mean? Yeah, go for it. Always put stuff in here that helps people. That's great. I'm all for that. I always try to find you guys the same stuff. Yeah, link all you want. I'm going to keep talking. The other thing, I talked a lot about hyponatremia in the elderly, and that is a big thing on page 121. I don't see it on this blueprint. Oh, there it is. Imbalance is common in elderly patients. I'm a liar. Sorry. It was just a little bit lower. So your elderly patients, this is a huge thing for them, hyponatremia and the elderly, right? So if you read that little yellow box, just know it's a major cause of morbidity and mortality in intensive care units and in the elderly, right? Hyponatremia here. So hyponatremia for elderly people contributes to cognitive deficits, gait disturbances, falls, fractures, long-term hospitalization, need for long-term care, and death. It's like a whole cascade that happens with them. So hyponatremia is really common for them. And then the consequences, even of them being off balance, can be life-threatening or ending for them. As you go down, what happens, right? So remember that. I don't know if you need to focus on contributing factors. SIADH is a big thing for elderly people. Diuretics, thiazide diuretics, hydrochlorothiazide, remember? Proton pump inhibitors. It's all in this little box here. Remember, we always increase someone's sodium level slowly because it can cause permanent brain damage if it's too fast. Osmotic demyelination syndrome. And a lot of times, if they're on the 3% saline, but really, even if they're on salt tabs to raise their sodium, got to restrict the water intake too. Okay. So with the electrolytes, I'm just going to hit high points because there's so much, right? Okay, talking about potassium really quick here. The big things about potassium, first of all, remember potassium likes to be intracellular, right? ICF for the potassium for the most part. Hold on, let me see if she puts anything else in here. Okay, All right, she doesn't. So on page 122 and the 1, 2, 3, fourth paragraph is where my info starts for my highlighting. So one thing to really pay attention to is that the kidney is the most efficient regulator of potassium balance. Why am I saying that to you? I'm saying that to you because patients that have renal disease or renal failure are at a much bigger risk for imbalances involving potassium. And potassium imbalances can be life-threatening. So you may have renal failure patients that come in and they haven't had dialysis in 3 days for some reason, and their potassium is like sky high. You know, it's like 5.7 or something, which in a renal patient is a terrifying number. Scary in anybody, but renal definitely. Or you may have a patient that has some renal disease whose potassium is low. You know, maybe they are a 3 or a 2.8, and that needs to be addressed as well. So remember that renal patients, whether it's failure or renal disease, are patients that you really have to be careful with for potassium imbalances, okay? Another thing here, a little bit below that, it says changes in pH and thus in hydrogen ion concentration also affect potassium balance. That's where I'm at. During acute acidosis, hydrogen ions accumulate, right? If we have acidosis, we have high hydrogen ions. Accumulate in the ICF, which is where the potassium likes to be, right? And it shifts potassium out of the cell into the ECF, the extracellular fluid. So that's a problem. So when we have higher levels, when we're measuring potassium and all these levels, we're measuring ECF, right? We're measuring the blood. So if the potassium is shifted out from the hydrogen ion into the ECF, if I took that blood sample, it would look hyperkalemic. So in acidosis, acute acidosis, you could have hyperkalemia. The other thing that I want to note here is on the top of 122. I don't see her really notating it here, but insulin, if you give insulin, it actually shifts potassium into the cell. So from the ECF into the ICF. So you could actually make somebody hypokalemic, right? It can contribute to that. Also note that diuretics like furosemide or Lasix, same thing, right? They cause you to lose potassium. So there are potassium sparing diuretics like aldactone, but most of the time you're giving Lasix, and those patients are at risk for hypokalemia because it actually pees out the potassium. Okay. All right, so I don't know if they will. I would just know that those are two things that are probably important to know in general. You know, like a lot of the stuff that you're going to learn in nursing school, you'll never, ever, 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 ever use again unless you tutor pathophysiology or something like that. But those two things, like in your practice, you'll know that they're at risk for low potassium from Lasix for sure. You'll know that anywhere you go. or insulin, especially like IV insulin. Mhm. Okay. So whenever I'm thinking about my monitor is dying for my kid. Whenever I think about potassium imbalances, I'm always thinking about cardiac. Like that's my biggest thing with them, right? How do we want to do this? I wish there was a table. I think you guys should make your own, to be honest. Just know that cardiac is a big thing. It doesn't hurt to look over all of this. There's a great little chart on 123. Do I think you need to memorize everything that happens within a cardiac strip for hypo and hyperkalemia? No. You know, like the ST depression for hypokalemia and that little U wave, that's kind of a big thing. And then for hyperkalemia, when I'm thinking of that, I'm thinking of those tall peaked T waves. Oh, for the electrolytes? That's good. Good, perfect. Go definitely review that. Like, let that be your guide, So potassium's neuromuscular and cardiac. Um, okay. So hyperkalemia. We talked a little bit about that already, right? The shift from ICF to ECF. Oh, here, look, 124 has table 5-6, hyper and hypo. The big thing for that, I can't stress it enough, and this is not as far as your chest goes, is dysrhythmias is on both sides. Huge risk. But that'll give you just an idea. If you didn't have time to make your own charts and you just wanted to look at that, there's your potassium alterations there. We already talked about renal patients can be on either side, hypo or hyper, right? Why do I have this highlighted? We're going over so much and there's 2 questions that come out of this. It's crazy, So on that note, I'm going to kind of hurry up when moving through this now. For high potassium, remember that insulin can lower potassium. So if somebody has risk, like if their potassium's high, one of the things we typically do is exactly what it says in your book here. We give them calcium gluconate. This is on page 125, evaluation and treatment. But the big thing is that we give them IV insulin, right? Regular insulin. And then we give them glucose, obviously, so that their blood sugar doesn't drop to some crazy level, and some bicarb as well. So that's one of the ways that we lower potassium. We also lower it through the GI tract with medication that pulls it out. No, anybody who's getting insulin, especially IV insulin, is at risk. Yep, anybody. So typically those people that are on insulin drips or some sort of stabilizer, there's different names for them. If not everywhere uses those. Like one hospital, we have the stabilizer and the other one, we just do drips, But everybody's probably getting labs every Q whatever hours, depending on the protocol. And then we're getting to those other signs because those two are in calcium. Which is, let's see, 126. So we already touched on this stuff, right? Okay. So she references 471. And I bet it's in our little table here too. Nope, or do I have that wrong? Yeah, 471. So talking about calcium. Let's see if this is. I don't know why they don't put that in the chart if she wants to ask you about it, right? It's not even in this chapter, but okay. So hypocalcemia, right? Kind of jumping there. Whenever you think of hypocalcemia, so Chopstek and Trousseau signs may be used to evaluate for neuromuscular irritability. So Chopstek, I'm probably saying it wrong. I remember this from nursing school. So you're tapping the cheek, resulting in twitching of the upper lip. Trousseau is going to be inflammation of the blood pressure cuff placed on the upper arm to a level above systolic blood pressure with resultant painful carpal spasm. It does this weird thing with your hands. Have I ever done this to somebody in real life? No, but I do remember this from school. And I don't know a tip to remember. Chopstek tapping. I mean, if it was Trousseau tapping, that would be easier. It's the opposite of what you would think, right? But remember that they both have to do with hypocalcemia here. So it's the tapping for Chopstek sign, and Trousseau is the blood pressure cuff inflated to over the systolic, typical systolic number for that person. And it does a weird spasm with the hand. I'm surprised there's not a picture of it. So think of both of those for hypocalcemia. Gee, there you go. See, yes. Cheek. Good. T tendon, I like that. So that's a good way to remember. Kayla just put in there. So remember, that's hypocalcemia, okay? Okay, so we kind of already went over this table. And I told you what I would pull from here, and it sounds like you guys have a little table to fill in anyway. But I would just pull out of these causes, right? If you can remember that hypercalcemia, one of the big things is hyperparathyroidism, cancer. Then you'll know with hypocalcemia, like hypoparathyroid, right? Decrease in parathyroid and vitamin D is what it says here. It can also be blood administration, whatever else. I already talked to you about about phos in general. So phosphate to me, most of the time when I see problems with it, it is from patients who are renal patients, you know, so they have some renal disease going on. Acute or chronic renal failure is what it says here for hyperphosphatemia. Hypophosphatemia, malabsorption related to vitamin D deficiency, or of course we have our antacids, right? Respiratory alkalosis and hyperparathyroidism can cause that as well. So hyperparathyroidism can raise your calcium and it can lower your phos. And then the magnesium we talked about earlier too. A lot of these are connected. Like if your potassium's low and it won't go up, you always want to check a magnesium level, because if your magnesium's low, it can also contribute to your potassium. I don't think that's going to be on your test, but just something to think about. Hypermagnesemia, usually renal insufficiency or failure, or you're taking the antacids, right? And hypomagnesemia, we talked about alcoholism, malnutrition. It can be urinary losses. And as far as those two signs go that we just talked about, it's positive if, just spit, it's gross. It's positive if you get the reaction, right? I'm making sure we covered everything on here. Okay, so on acid base, which is a huge section, right? So know your values: pH, bicarb, CO2. We talked about impact on electrolytes. The only thing that I've read, and I could be wrong, right, in your book, is what happens with the potassium when it's a really acidotic environment. That high hydrogen ion it can cause hyperkalemia because it shifts the potassium from intracellular to extracellular. But if you guys see something else, feel free to speak up, The big thing that I want you to understand with acid-base balance, yeah, and a lot of people like that tic-tac-toe method. So watch that for sure if you're having some difficulty with it. Remember that you're not going to be tested on uncompensated versus compensated. They're only going to have the uncompensated ABGs on your test, because that's what they want you to know, right? So remember things like, if I am only breathing 7 times a minute, what's happening, right? If I'm breathing 5 to 7 times a minute, I took a whole bunch of pills and now I'm overdosed and I'm barely breathing. I'm not allowing for that gas exchange. So I'm holding on to CO2. I'm not blowing out enough CO2. That hydrogen ion, CO2, all this is building up in my body, right? Yep, which is respiratory acidosis. That's exactly what that would cause. So hypoventilation will cause more of a respiratory acidosis, right? Versus hyperventilation, I'm going to blow off the CO2. That's going to make me more into a respiratory alkalosis. Or if my body is in metabolic acidosis, it's going to try to compensate by Kussmaul respirations, or just hyperventilating, right? And to blow off more and more CO2. It's going to try to hyperventilate. Does that make sense? Body's always going to try to compensate. Do you guys have questions on that? That's a big, like, you're gonna obviously, I don't even have to say it much. There's 7 questions here, right? 7 questions. I always move around a lot in these chairs because they're uncomfortable. So if you don't get it, ask me. Let's see. Your signs of your metabolic alkalosis are on the bottom of page 128. That's one of your questions. One of the things she lists on there. Weakness, muscle cramps, hyperactive reflexes, tetany, confusion, convulsions, and atrial tachycardia. It says respirations may be shallow and slow as lungs attempt to compensate by increasing carbon dioxide retention. That makes sense to everybody? I only read that for the compensation part there. That if in metabolic alkalosis, my lungs are going to try to hold on to more CO2 with slower breathing, right? Table 5.8? No. I mean, know your arterial blood. 7.35 to 7.45, right? You probably already know that's the whole thing here. But no. Nope. I would have to look up almost all of those. We talk about urine in a few chapters, in a few modules. Here you go. Here's another symptom that I actually have highlighted here. The symptom of hyperactive reflexes and tetany occur because alkalosis increases binding of calcium to plasma proteins, thus decreasing ionized calcium concentration. So alkalosis can cause a decreased calcium concentration. I wish there was a good chart for you guys here. And if you look, oh, go ahead.
Sorry, what page were the signs of metabolic alkalosis again?
That was 128 at the bottom. Yeah, I wish you guys had I wish they had a better thing here, but I haven't come across it.
I'm not seeing that. I'm seeing, like, my page 128 has respiratory acidosis, like, just described as, like, one of the regular paragraphs.
It's on the very left. It says some common signs and symptoms of metabolic alkalosis are weakness, muscle cramps, hyperactive reflexes. Yeah, the bottom left corner.
Of page 128?
This is what mine looks like. I don't know if it's in the picture or not, but
Oh, I'm sorry. I thought you said it was, like, its own table.
oh, sorry.
Sorry.
No, I said I wish you guys had a table.
Oh, sorry. Go on.
Okay. I probably said it wrong. But one thing, there is a table here on page 129. So causes of metabolic acidosis. Now, I don't think that you need to be like, oh, well, that's an increased non-carbonic acid. You don't need to know that, okay? This is just an example to things that can cause metabolic acidosis, including diarrhea. Right, so renal failure, diarrhea, ketoacidosis, which obviously just by the name of it, DKA, diabetic ketoacidosis, right? Shock, which is lactic acidosis, hypoxemia. So just general looking over this, things that could cause acidosis. Okay, renal failure, things like that. I skipped over your metabolic acidosis signs. They're right on the page before. It's only like in the bottom paragraph of it. That's on 127. I'm gonna let you guys pull those symptoms out of each thing. I'm not really helping you by just saying that. Same with respiratory acidosis. They're here too, and alkalosis. Okay. Innate immunity and the 3 protein systems. Those are the other big things, right? Okay, so innate immunity, we have 6 questions coming out of here. And that includes the proteins. So that'll work. All right, good luck. You're welcome. Okay. So the big things here, so the types of immunity, which we'll go over and all the other stuff. So First and second lines of defense. First and second lines of defense. Inflammation and inflammatory response. Okay. This is usually set up a little bit different, so it's throwing me off. All right, so forgive me if I jump around a little bit. Big things here. Remember, remember innate immunity. So that's basically things that we have from birth, right? Physical, mechanical, and biochemical, and inflammation. So things to think about for that always throws me off are an example of if I was to get a paper cut, that is already going through my innate immunity, right? My skin is actually part of my innate immunity. So it's a natural barrier. Normal flora or the microbiome that we have, that can be part of that as well. If we talk about normal microbiome or normal flora in a minute here, so. Inflammatory response, we'll talk about in a moment. That's a whole cascade of activated cascade, and then adaptive immunity, also known as acquired or specific immunity. So it's induced in a relatively slower and more specific process and targets particular invading microorganisms. Also involves memory, which helps for a more rapid response if there is introduction of that invader again in the body. Okay, so innate, we pretty much touched on everything I want to say here. Oh, other things with innate immunity, with the physical barriers that I have highlighted here. So of course our skin, like we just talked about, right? But also things like dead skin cells being sloughed off since they're routinely replaced, that's part of that. Coughing, sneezing, vomiting, diarrhea, peeing something out, all of that is part of our innate immunity, okay? So anything we can do to rid ourselves of irritants or invaders in our body. Cellular receptors. Which parts? Like, where are you? Page 142. No, you're not going to have to know all of this. Does she give anything?
I'm sorry, was she referring to table 6-3?
You definitely don't have to know that.
Oh, yeah. Oh,
Don't worry. You don't have to memorize that whole thing. Parts of this are going to be in your reading, like little parts though. But no, you don't have to memorize that table. Yeah. And then 142, you're not going to have to know all of these. Let's see if, does she give us any further phagocytes? Phagocytes, whatever they're called. Where's Edward? I don't think inflammation. I can't tell if she's doing that. Normally it has like the header of the, where you have to focus, you know? That's what I was looking like on here. Like she'll have innate immunity. And then, well, she does have it up there. She'll talk about the little things that we need to talk about. So if you don't see it, oh man, that's so general. I know they didn't really narrow it down too much. We just have to do the best we can with the blueprint that she gives us, you know? Yes. Yeah. And I didn't see her review, but I would definitely, anything extra she says on there is purposeful. You know, that's been how it's been. So if you haven't watched that yet, I know that sounds like she just talked about the blueprint in general a lot. But if you haven't seen it, watch it, because if she's really stressing the 3 mechanisms and then, you know, the protein systems there, then we need to focus on that. It's hard because I could tell you that whole section's null and void and they can pull one thing from it. Do you know what I mean? So let me move through here then. Because she does say first and second lines of defense. We talked about that. So inflammation, that's the other thing, right? Inflammatory response. So if you look on the bottom of 137, I kind of skipped over it. I talked about microbiome normal flora, right? Like the microorganisms that colonize different parts of our body, the body surface, whatever, how those are part of our immunity, right? They keep the pathogens in check. They also carry on lots of different functions in our body. I'm going to kind of skip over that more, but chapter 6, 134, 137, 1 in the moon here. Okay. Let me just peek at that. Yeah, and 147, oh, I'm lying to you, 147 or 146? We'll look at it in our next 30 minutes. Okay. So inflammation, she definitely has this on here too, right? And the inflammatory response. So if you look on 137, trying to go through this quickly. Inflammation programmed to respond to cellular or tissue damage, whether the damaged tissue is septic or sterile. So this response happens the same way every single time, no matter if it is the tiniest insult or a massive insult, right? Like it occurs how it occurs, okay? So activated rapidly, depends on activity of both cellular and chemical components, is nonspecific, meaning it takes place in approximately the same way regardless of the type of stimulus or whether exposure to the same stimulus has occurred in the past. So if you look at this, some of the big things, the next part of the page, so you have redness. Oh, Edward, I believe, had a good way to remember this, and I can't remember what it was. But you had the redness, swelling, pain, heat, herp. I knew it was something like that. And loss of function was A, right? Herpa? Or was it? It was something. That's how you remember your inflammatory response. Like that's your symptoms of inflammation, right? Like that's what we're looking for. That's our inflammation signs there. And then, you know, of course, if somebody has a fever, that's systemic inflammatory response, right? Heat, redness, heat, edema, redness, pain, herp. That's right. Okay. Now, right underneath that, it says 1, 2, and 3. It's vasodilation, increased permeability, and white blood cell adherence. Like those 3 things I do have highlighted here just for the process that's taking place. Okay, screw it. I'm just going to say it. So vasodilation, the blood vessels are going to vasodilate, right? So slower blood velocity, increased blood flow to the injured site. Increased vascular permeability. So it's more porous. So things can get out of the vascular space and into that tissue that's been injured easier, right? So it's leakage of fluid out of the vessel, which is called exudation, swelling, and increase in blood flow and increasing concentration of red cells at the site of inflammation, which causes the redness or erythema with warmth. White blood cell adherence to inner walls of the vessels and their migration through enlarged junctions between endothelial cells lining the vessels into the surrounding tissue. So there's your microscopic inflammatory changes summed up there, okay? Okay. So we have lots of things happening at once. So plasma protein systems and inflammation. So this is what we were referring to in our messages here, right? So what do I want you to know about the complement clotting and kinin systems here? So complement system is a large number of circulating proteins. They can destroy pathogens directly or can activate or increase the activity of many other components of inflammatory and adaptive immune response. All right, so what I've highlighted here, factors produced during activation of the complement system are among the body's most potent defenders, particularly against bacterial infection. How do I summarize this next paragraph? So I'm just going to read this part. I don't like how it's worded. The most important function of the complement cascade is activation. I don't think you need to know C3 and C5, but just know that the most important part of the complement cascade is activation of C3 and C5, which all right, we'll just read it. Results in a variety of molecules that are opsonins. So basically, when part of the complement cascade that happens that's the most important is the opsonins, which coats the surface of the bacteria and increases their susceptibility to being phagocytized, probably saying that wrong, and killed by inflammatory cells such as neutrophils and macrophages. So that's the big thing, is that from the complement cascade, this bacterial coating goes on. I don't know if you need to know that or not. And it increases the bacteria's susceptibility to being phagocytized and killed by inflammatory cells such as neutrophils and macrophages. That is courtesy of the complement cascade. All right, other things that happen during the complement cascade are rapid degranulation of mast cells, which releases histamine. You're going to see histamine throughout this chapter. Cool. Kayla shared a video, you guys. Oh, see, Edward? There you go, summarizing it for us. This is Edward's thing right here. This is where he's going to excel on this test. But Kayla also shared a video here for the complement system, so don't make me. I'm just impressed at how much you remember. And I don't think I ever knew this in the level that you do, you know? Hold on, I think this is going to end up playing and I don't want it to. I'm sorry. There we go. Okay. Oh. So cute. All right. So when you think of degranulation of mast cells, think release of histamine, which induces vasodilation and increased capillary permeability. And we talked about that earlier when we were talking about inflammation, right? Vasodilation, increased permeability. All right. Clotting. So I'm going to skip to clotting system. It's really hard to figure out exactly what to give you here, but let it just be additional to what you know. So clotting, coagulation system, group of plasma proteins that when activated sequentially form a blood clot. So a thing to know is obviously the definition of a blood clot. What you didn't know is it's of course not just platelets. So work of protein, fibrin, strands that contain platelets, which you probably thought, and traps other cells such as erythrocytes, phagocytes, and microorganisms. And so there's kind of a mixture in there with all that fibrin. It's a catch-all. So they plug damaged vessels and stop bleeding, trap microorganisms and prevent their spread. and provide framework for future repair and healing. Converge, result in formation of a clot. Hagman factor. Why is that in my head? I think it's because the kinin system. So the third plasma protein system's on page 140. It's the kinin system. Interacts closely with the coagulation system. I don't want to say no, but I don't really have anything highlighted in here. Let me look at my notes and my other thing in my paper. My initial response is it's not something I necessarily focus much time on. You know what I mean, Jelly Bean? And I think I still feel that way. Okay, first and second thought is I wouldn't focus on it. But I always reserve the right to not be 100% right all the time, you know? But that's my thought. With the kinin system, so here's a little thing. Now, I had the Hagman factor in my head, right? And I have this highlighted. Is it for you or is it for me? I don't know. But both the clotting and kinin systems can be initiated through activation of the Hagman factor, which, as we learned last session, is 7, not 12. No, it's 12, not 7. So Hagman factor, 12. Activate kinin and clotting. No, I highly doubt it. I highly doubt it. Yeah, I'm going to go with no. I wouldn't focus on it unless you just want to learn more. Okay. First component. The final proponent of the kinin system is a small molecular weight molecule, bradykinin. Okay. So final product, kinin system, it's activated. Great, we're going. Hagman factor, did it. Wonderful. Final product, bradykinin, which is produced from a larger precursor molecule. Who cares? You might care, I don't know. Bradykinin causes dilation of blood vessels, acts with prostaglandins to induce pain, causes smooth muscle cell contraction, and increases vascular permeability. So you can see this multi-system approach that's happening to do all the things that we talked about with inflammation, right? So again, bradykinin, dilation of the blood vessels, induces pain, causes smooth muscle cell contraction, and increases vascular permeability. Okay. All right. So, yeah. So, all right, I hate trying to summarize this. I don't know why I have this highlighted, so I'm just going to read it to you. First of all, control and interaction of plasma protein systems. I don't know that you need to know anything out of here. Don't know. But it talks about how interactive these systems are and how they have to have very tight regulation, because if it, as we know, when our immune system attacks healthy tissue, it causes problems, right? Or healthy systems, or whatever you want to call it. So it just talks about some of the mediators here. It wouldn't hurt to look through it for a general idea. I don't know if it's something you need to focus on. If so, it would be small, but just know that there's obviously things that have to start and stop all of these processes to keep them in check, right? Other thing is cellular components of inflammation. So again, I have highlighted, we already talked about this, it's a process in vascular tissue. This is kind of a repeat as well, but what I have here is on 141, it says the tissues close to the vessels contain mast cells, which are probably the most important activators of inflammation, and dendritic cells, which connect to the innate and acquired immune responses. They like those questions, right? Dendritic cells connect to the innate and acquired immune responses. I don't know why that's highlighted on here, but it is. This is page 141. And sometimes I'll read you stuff that's highlighted and it's going to be really specific to what you need to know. And other times it was something that I said, oh, that's interesting. Let me think about that. Okay, let's hop over to, we have 10 minutes here. So she says, phagocytes, types, roles, and regulation. So on 146 is where I have the phagocytes starting here. I know she had said 147 to you guys, somebody had typed. But on here, it's talking about phagocytes, types, roles, and regulation. Excuse me. So here, what I would do is I would just highlight little important things in here. Like for your neutrophils, well, first of all, phagocytes, primary role of most granulocytes, neutrophils, eosinophils, basophils, and blah, 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 is phagocytosis, the process by which a cell ingests and disposes of damaged cells and foreign material, including microorganisms. So these are the things that are eating the stuff that doesn't need to be there, right? So neutrophils, big thing here is primary role, removal of debris and dead cells and sterile lesions, such as burns and destruction of bacteria in non-sterile lesions. That's the bottom paragraph here, right? Now, I'm really summarizing, but you could pull important stuff out of there like that, right? The eosinophils, this is the one that I told you I thought was super interesting because one of the functions that it does is to serve as the body's primary defense against parasites. So again, if you had somebody with a high eosinophil count, right, like they're ill and you don't know why, and their eosinophils are markedly high, you'd be like, oh, that's interesting. You know, could this be a parasite? They also help regulate vascular mediators released from mast cells. So eosinophils, you're going to think parasites. That's really the big thing for them, and I can't forget that. Basophil, probably not going to have many questions for that, but it says often associated with allergies and asthma, primary role is yet unknown. Oh gosh. Let's see. It is, Taylor, and I can only narrow it down so much, you know? It's so wide. It is so wide. It's super hard to do. And we don't even have enough time to do it. You know, there's not enough time. I know. I get stressed for you guys. I know, right? It'll be the one thing. Well, let me tell you this, because we're pretty much at the end of our time here. Actually, before I do that, page 149. Does she do acute versus chronic? She does. There's one question in acute and chronic inflammation. I'm not going to go over it, but I told you in the past, they like acute versus chronic questions, right? So acute inflammation, HERPA, results from vascular changes and subsequent leakage of circulating components into the tissue, right? Where's our chronic part here? Chronic inflammation lasts 2 weeks or longer regardless of cause. So superficially, the difference between acute and chronic inflammation is duration, right? They like those questions. It's on there too. But what I want you to do with this test is don't panic. Answer, if you know it, great. Otherwise, do what you do with all test taking. There's 2 answers on there. First of all, make sure you're reading the question correctly. There's always going to be 2 answers that just don't make sense. You know, they just don't. And then you got to go from there. So you got to play the odds and at least narrow it down to 2, right? With your studying, I already told you, make sure to just focus on the numbers, you know, the high question areas. If you absolutely can't get to part of the guide, read the did you understand in the back, right? I would love, I didn't get your test schedule until after I made my schedule. And that's just because somebody sent it to me. So I still need to put those in my planner. I would love to tell you that I'm going to try to get a session in before your test, but I just don't. I work Tuesday. I work tomorrow. I just don't know if it can happen. But if it does happen, I'll try to blast something out and they'll post something. But I highly doubt that we can squeeze in another hour. We'll see. Because I have to get childcare, or we can just hope she behaves for an hour. That's sometimes what I have to do. Maybe we'll do that. I have to see what Monday looks like, but no guarantees, you know? Let me look at your study guide real quick and see if anything stands out. Really look at that wound healing. It's a small section, right? Like there's that picture and it sums up a lot, and just know what that picture is talking about. The age-related factors in immunity, that table, like that little box, the purple box, yellow, I don't remember what color it was. I would look at that. That's the only place that that's going to come from. Chapter 7, there's only a few questions here. Let's see. At least we've covered your big things here. Nothing really sticks out for anything crazy. The purple and green on 154. Let's see. Oh, yeah. Yep. Yeah, know that. That's a compact place for you guys to look at, you know? Infection and ischemia for the wounds. Let me look at it. I don't know. I don't know. anything that's not really. Let's see here. Let me look at it real quick. Lymphocytes and antibodies. So the T helper cells she mentions in a couple of places here. So B cells and T helper cells. Let's see. See if there's a good table for it. T and B is like recurring in her little, that one section there that she mentions them twice, you know? No, not too much, unfortunately. Nothing really big that stands out like as something to go over. You know, this is a lot of definition, like a lot of definition here. But honestly, what I would do is wherever you see, just understand adaptive immunity, the antigens, immunogens, and antibodies, like highlight those areas and just look at that. And then the immune response, I would focus on B cells and T cells, T helper cells. And just highlight like the definitions or the words that she gave there, just know exactly what she's talking about. Don't get lost in the other areas, like clonal selection, for example, on 167. Like, try to really stay laser focused on only the things she listed. Awesome. Kayla got another link on there for you guys too. I'm going to put this. I'll save these. It might start playing.
Got us thinking.
Whoop. So, again, if I can get you guys in on Monday, I just don't know. I got family arriving from Costa Rica on Wednesday too, so I feel crazy. You know, you're welcome. Good luck other than that. Don't psych yourself out. These tests are hard. This is probably the least amount of information covered on any of them. So it's a good warm up. Just look at the questions, X out what you know isn't right, and just do your best with it, okay? You'll do great. You're welcome. I'll see you guys Thursday. I'll let you know if it's before that, okay? You're welcome. See you later.